Hello, my name is David Kooby. I'm a surgical oncologist with Emory University and the Winship Cancer Institute in Atlanta, Georgia. I focus on gastrointestinal malignancies and primarily on foregut malignancies, which would include malignant tumors of the benign and malignant tumors of the liver, stomach, pancreas, and intestines. The question is about carcinoid syndrome and intraoperative carcinoid syndrome in particular. So first we have to get to the discussion of what a carcinoid syndrome is and what carcinoid tumors are. So carcinoid is a term that is derived from the word carcinoma-like. So these are tumors that, if you look at the tumor itself, you think it's just like any typical adenocarcinoma. However, when you look at them under the microscope, you will see that they have a monotonous array of cells that produce that are capable of producing hormones. And really, this is the root of the origin of carcinoid syndrome, because then the chemicals that these tumors produce, the main one is serotonin, but others such as histamines, bradykinin, prostaglandins, et cetera, can be released from the cells and the tumors in big quantities, supraphysiologic quantities, that can result in changes in blood pressure and other symptoms. The most common one is going to be hypotension. So in the operating room, two factors that can influence a tremendous release of these chemicals are anesthetics and surgical manipulation. Probably the most interesting scenario, or more common scenario, would be a neuroendocrine tumor of the adrenal gland, or something called a paraganglioma that produces catecholamines. These patients and these tumors, when they're recognized, we treat them medically in advance with alpha adrenergic blockade to prevent a release of catecholamines in the operating room, which can result in severe hypertension, which can also result in cardiac and cerebrovascular events, actually can kill the patient in the operating room. So that would be the more common scenario where we talk about severe release of a chemical from a tumor. And the description for the surgeon is once the patient's adequately blocked and we get the patient safely under anesthesia, is to actually dissect the patient's body away from the tumor and kind of have that mindset rather than dissecting the tumor away from the patient. So coming back to small bowel carcinoids and neuroendocrine tumors, which I think is really our focus today. The interesting thing is, if you have a primary tumor, it's unlikely to produce carcinoid syndrome, and you don't typically have to worry about that in the operating room to have an event such as this, because any of the chemicals that are produced from the primary tumor are typically metabolized in the liver, as all the blood supply from the intestine is going through the liver before going through the rest of the systemic circulation. And when it's metabolized, it's not vasoactive and isn't causing the symptoms. So the patients we have to be aware of when we're taking them to the operating room are those, especially with known functional carcinoids, who do have liver metastases, because then any of the hormone that's produced by the metastases themselves will enter the systemic circulation before they are metabolized by the liver, and then can create an intraoperative carcinoid crisis type situation. So what happens if you see that? I've been very fortunate in my career, almost 20 years, to never have seen that in the operating room. Certainly, if we're concerned about that, the patients are treated in advance with a somatostatin analog, typically octreotide. They are started 12 to 24 hours earlier on a drip and then maintained in the operating room with somewhere around 0.5 to 2 micrograms per kilogram a body weight on a drip throughout the case. Appropriate fluids are given, and appropriate agents to support blood pressure are available to the anesthesiologist as well. I have one amazing, profound case of a patient that I treated early in my career who presented with carcinoid syndrome, and it was extremely severe with metabolic derangement, low sodium and potassium. He had severe diarrhea, flushing, hypotension, and he presented with actually pancreatic neuroendocrine tumor in the body tail, and he had as many as 12 hepatic metastases. So when we met him, it was through the emergency room. We sent him to the intensive care unit on fluid support, started octreotide, and almost overnight the patient improved dramatically. Once he was stabilized, I got to know the patient, saw him in the office. Then we counseled him that we could remove the primary and then the hepatic metastases. We did. And I treated this gentleman for over 10 years when he presented almost at death's door. And over the course of a pancreas operation, 2 or 3 liver operations, several ablations, and liver-directed therapy, the patient lived another decade with metastatic disease. Probably now, with the agents we have available, he probably would live even longer. And from the medical options we have now to manage this. But that was a very dramatic and sort of memorable case for me in my career. So I think the take-home message on carcinoid syndrome is to have an appropriate high level of suspicion going into an operation, to not show up to the operating room blindly and experience it in the operating room without being prepared, to have a discussion with your anesthesiologist in advance, have appropriate IV access, have access to the somatostatin analogs, to think about this in advance. And certainly if it just happens in the operating room when you're not suspecting it, then to have it on your differential list so that you're prepared to treat it if it comes up.